Heart disease is the leading cause of death amongst women worldwide, accounting for 35% of female death, more than all cancers combined. Yet, it still remained underdiagnosed and consequently undertreated, often due to a low perceived risk and a delayed recognition of symptoms. For those who doesn't know me, I'm Dr. Alba Pereira. I'm an NHSGP, a menopause specialist, and a board member of the Royal College of General Practitioners, representing the North and West London faculty. It's an honor having you all here tonight at the Royal College of General Practitioners, the home of GPs in United Kingdom. My view today is not going to be just about women's health, but on how we are delivering care. Primary care is under an extraordinary pressure. As population ages, long-term conditions rise sharply. Disease that used to be just diagnosed in the primary care, such as hypertension, type 2 diabetes, and immediately referred to the second care, are now mainly managed in the community. GPs nowadays hold far greater clinical responsibilities than even a decade ago. Paradoxically, the proportion of the NHS funding allocated to community service is getting smaller and smaller as resource is being direct to second care, where treatments are significantly more expensive. Yet, secondary care is also under an enormous pressure, with growing waiting lists and decreased capacity. These results in a circular burden. For instance, a patient referred to the second care can face a 12-month or more waiting list to be seen. This unresolved clinical problem keeps coming back to the GP for help, because the patient, usually in distress, looks for ongoing support. So, we can see that we are holding more long-term conditions, plus the patients are not getting through the door easily to the second care. And GPs' roles go far beyond clinical responsibilities. Far beyond. We are asked to assess housing needs, support universal credit application. This week, I was requested to support with work capability by the Department of Work and Pension to respond to private insurance requests. We have to support safeguarding domestic violence, social vulnerability, the public health consequence of deprivation. GPs still remain accountable for quality outcome framework indicators of health, cough, asthma, depression, smoke cessation, obesity. I don't going to bother you all because there are 76 altogether. And now, weight loss injection is going to go for cough as well. So it's going to be 77. It's quite a demanding environment. And morale in general practice is fragile. With clear disconnection between policymakers and frontline reality. Yet, general practice remains the foundation of the NHS. And that's why I am delighted tonight to have a menopause specialist and a cardiologist consultant to give us some insights, to show us the evidence, the contradictions, to show us how can we support the foundation, the community. To all of you here tonight, your presence here demonstrates that despite of the all political, social, economic turbulence out there, we still remain focused on our patients and in our community. Thank you all for coming. Our session today is going to be divided in two, education and then afterwards, networking. The first session, the education section, we are going to talk about first cardiologists, then a quick 1 or 2 Q&As just for us to swap the slides, then menopause, and followed by a longer Q&A session at the end. Yeah, I'm going to show some point a QR code for you guys. Please leave feedback. There is a long time not just sort out this feedback form. She wrote so many questions for you. Don't bother about the majority of them. I just want to know 2 things, 1 positive and 1 negative. I just want to know 1 positive and 1 negative. It must have 1 positive and must have some negative. Perhaps something that I cannot act on. For instance, you guys can say that next event you would like to have on the Buckingham Palace. Sorry, but at least you'll be good to know that.
It's under renovation. It's in Windsor Castle.
Yeah, so, but at least it's good to know that perhaps I should try to find another venue. This is just an example. And some positive as well for us to carry on. Yeah. So without any further ado, our first speaker, that it's a pleasure. Thank you for coming to donate your time. Is Dr. Ricardo Petraco. He is a cardiologist consultant at the Imperial College, One Heart, and Mayo Clinic, London. He leads the Rapid Access chest pain clinic at the Imperial College. He teaches globally on intracoronary diagnosis and conducts research in coronary physiology. His current work, very exciting, focuses on using artificial intelligence to improve coronary imaging interpretation. Thank you, Dr. Ricardo Petraco.
Thank you, Alba.
The floor is yours.
Thank you so much for the invite. It really is a pleasure. When I'm invited to give talks mostly around coronary artery disease, I never feel that I'm going to learn so much. And tonight, I've learned a lot preparing this talk and also waiting to hear Prof's talk later. And as Alba said, it's going to be hopefully a very interactive one where we're going to ask many questions. Some of them we won't know the answer. I am lucky or unlucky in many ways because I am a general cardiologist. I'm one of the screening cardiologists at Mayo when we do cardiovascular screening. And I go all the way to the other end that I'm an interventional cardiologist. So I spend a good part of my week putting stents into people with heart attack. So sometimes you see us cardiologists talking to UGPs a bit frustrated because we see the bad ends and you have a huge denominator of people that are out there actually not much problem. So today, perhaps you're going to try and find a way of combining it and specifying amongst all your population of patients who actually needs a higher risk assessment and treatment. And I also lead the rapid access chest-pain clinic at Imperial, which is a huge service led by nurses that you referred all the time to multiple rapid access, and is an amazing survey evolving that is trying to bridge this gap between the primary care and us. So we're going to review some basic concepts of atherosclerosis, so things you're not going to read before you go to bed. Discuss cardiac risk, how perhaps gender affects risk over a lifetime, particularly relevant to women and the menopause talk tonight. And I'm going to update on some current recommendations and risk stratifications and treatments. So you are, as Alba said, inundated with work of a multitude of chronic conditions, and you have people with pains everywhere. But there is one particular type of pain that incurs a risk, which brings up the risk assessment. So there's a reason why you guys, when you receive an X-ray of a knee, you don't call an orthopedic person immediately because you're worried, are you? But you're going to get an ECG that you're not quite sure about. You always get anxious. And we have real footage of this. Of one of the GPs that works closely with me is constantly asking advice about ECGs, which I'm always very, very happy to give advice, because I know that this is an Achilles heel for you and puts you at a huge amount of pressure, and it shouldn't be like this. That's why we should have more of such sessions to discuss. And as Alba said, this is the data across the road for death caused by strokes and myocardial infarctions only, not even including all the heart failure, dissections, peripheral vascular disease. This is just MI and stroke. And look how relevant it is in terms of the morbidity and mortality that it causes across the globe. Some places less than others because other disease kills them more. But in general, it is the biggest killer. And that's why when you look at an ECG, you're worried about that. So in one slide, the only perhaps technical slide of the night, let's remind ourselves what is this condition that is so horrendous that can kill us more than anything else. On the left there, this is working with a TV. On the left there, you have an artery, which is the normal coronary artery, Alba's artery. Yeah? Beautiful, a muscular layer covered inside by what you call the intima, which is the endothelial layer, that with time will start getting thick, and cholesterol start entering that artery. And this lifetime of disease progression here perhaps is what essentially defines atherosclerosis, which is a progressive deposition of cholesterol inside our arteries, particularly coronary arteries and cerebrovascular disease. And in more details, which will be relevant to what we discuss later, essentially, coronary artery disease and atherosclerosis is an inflammatory condition. It's a low-grade inflammatory condition where you damage the endothelium with high blood pressure, with smoking, and with sugar. We make the LDL cholesterol oxidize that is engulfed by macrophages. They go into the wall. They create more inflammation. That inflammation generates a cycle that feeds to each other. And actually, we can detect that inflammation blood test. That's why high-sensitive CRP is a test that sometimes help to define who is at risk. And, of course, at the end, that thin fibrous cap there, which is our the protection against ruptures, and then you have a myocardial infarction. And there is a major focus here, and everything you're going to read about atherosclerosis is all about the LDL. LDL is one of the main particles, that brings that cholesterol inside the atheroma. But there's a new kid on the block, which you heard about, and that's the lipoprotein A, which you must have seen before. You're going to be inundated by this now because a lot of people are going for private assessments and they have an Lp(a). It's raised. The people who do the private assessments know nothing about it. And they say, go to your GP to sort it out. Yeah. And Lp(a), as you can see there, is very similar to LDL cholesterol. There's only one protein difference between the two. And that's why it's a highly atherogenic particle that causes atheroma and increased risk of thrombosis as well. Hope you're going to remember that forever. Yeah, that's it. So the other big aspect of it, which is one of the most challenging things for us, which is atherosclerosis, is a chronic condition that starts pretty much at birth. Unfortunately, I'm going to look at you and say that a good proportion of us in this room here have atherosclerosis there. I'm very happy to have atherosclerosis when I'm 90, 95. And some people don't have. I've scanned a few of you already, and some people don't have atherosclerosis, but in general, we have a bit. And I'm quite happy to have atherosclerosis when I'm 90, maybe 80, 85, a bit of plaque in my carotids. I don't mind that. The problem of atherosclerosis is when it becomes early, aggressive, and leads to early cardiac events. And what is the hardest bit for you guys dealing with prevention is that 99% of the time of patients coming through their lifetime of atherosclerosis have no symptoms. And 50 to 80% of that disease is completely preventable by managing those risk factors. And you can see the chap on the top there. He was born, he was quite a slim guy, started eating burgers, started smoking, had a stressful job after that, and he had a heart attack later in life. There's so much we have been done to prevent this. And our job, the hard job, is to find out how do we do it? How do we prevent that risk? How do we identify this? This is just a simple demonstration that when you're seeing someone with a heart attack, post-MI, stroke, or peripheral vascular disease, you're seeing the end of that disease process. Yeah? It doesn't mean that it's too late to do something about it, but you can't expect for us to reverse that disease that's been there for like decades, since they started eating the first burger when they were young. And therefore, you have this lifetime of the disease, which I will see a lot of people coming with heart attacks towards the end, but you have space for intervention. That's the good news. We have a lot of time to work on it. And even from the early childhood, I have 3 kids, 2 of them are a bit older. And one of the first things I've done in their life when they were kids, I scared them about cigarettes. Yeah. So to the point that when they were a bit older, they came to me and said, "I've just seen someone, she's smoking." So I like that. So I've engraved in their brain that this is a problem. And the same thing applies to ultra-processed food now. So you know those little sausage that you can buy? I don't know the name of it. Yeah. No, it's quite good. That's a posh one. There's a middle class. I'm talking about the other ones, the cheap ones you buy dry. No, is it? Like, yeah, one of those. So my 10-year-old calls it cancer in a stick. Yeah. So he's already in his brain before he can make his own decisions. Implemented some of my ideas into his brain. And the point I'm trying to make here is that our culture and the way we teach our kids how to behave, how to eat, how to exercise is actually really relevant, because later on in life, it's going to be automatic for them to behave well and to have a healthy life. By the time they get to their 40s, when they're working, trying to sustain a family, it might be not late, but the disease will be established by then. So we have that window of time in the mid of our life to decide who we're going to screen to detect that disease, to treat more aggressive. And that's what I'm going to talk to you today. So stereotypically, and you're going to try to find out today whether that's the case, before the menopause, we are at higher risk. Yeah, we can get angry about it, we can discuss, we can shout, but that's the reality. Yeah, there's the estrogen offering some protection to vascular disease. And then we think that through the process of menopause, there's a change in the metabolic profiles that increase your cardiovascular risk. So to the point that after the menopause, we catch up with that risk between you and us. I mean, there's not a fight here, yeah, but you know, between the genders. So this is what the theory tells us, and the story that we hear, and the clinical impression we see in clinical practice. But actually, when you go to the risk calculators, it tells you a slightly different story. This is an app that we are developing that is not quite ready for public use, but we're developing an app where we're putting all the risk scores together, including lipoprotein A, calcium score, to give us an idea of how to manage that risk in primary care and in cardiology. So the app will be ready in a few months' time, but at the moment what you can do is play with it. So I've asked my fellow to do is to put fictitious patients here and create 3 groups. This is a low, sorry, this went too far. This is a low risk group, yeah? When we said pretty good normal blood pressure, okay cholesterol, okay HDL, BMI 22. Look at the proportion of theoretical events in 10 years, or your risk in 10 years across the 3 biggest scores we use, which is score 2 in Europe, PREVENT in the US, and Q-risk 3 here. You see a very similar story, that the male risk is significantly higher than the female risk across the age groups. And the same thing applies to the high-risk patients. So someone that's historically 165, cholesterol of 6, BMI of 30. You see the numbers change, but the proportion seems to be the same. And then when you put one on top of each other, you can create a relative risk, and which means male over female. And then you have the line of 1 here will be obviously if it was equal. And you can see throughout our lifetime, the risks prediction means that it's pretty much stable, that the risks are up and actually go down with age. That's what the risk scores are telling us, yeah? Now, when you look at the real data, this is from the UK Biobank, the risk of myocardial infarction, of course, increases at both ages. That's normal. But it increased more so with women. So when you create that ratio of risk between male and female, what you see is the opposite of the scores are trying to predict. That actually, when you're very young, you pretty much only see males having myocardial infarction, heart attacks, and strokes, or in this case, MIs. And then you actually go through your lifetime, that risk balance out to the point that by the time everyone is having a heart attack in their 70s and 80s, the risk is 1-to-1, yeah? And you can see on that white line, that famous gap that people say, actually it's all the same, you're just 10 years behind. And it's probably true. By the time you look at the amount of event rates that you can get on a female versus a male, it's just the same but 10 years later. So what the estrogen is giving you is a 10-year catch-up for you to be able to actually have more time to prevent this from happening. So it's a good thing if you see it from that way. The stroke is not that different. Both increase with age. For some reason, is not as protective, at least according to the UK Biobank data. Yeah, it both increase equally. Now, when you superimpose the scores in myocardial infarction or the predictive risk to the actual risk, you can see, as I said, a different story. That the risk is increasing for both, but the proportion of risk or the predominance of that risk in males is going down with age, to the point that when they get older, it's pretty much all the same. So this story here is correct. We are protected. We are 7-10 years ahead of you with risk, unfortunately. And then things change in the menopause, and you're going to learn all about it more later. And then at the end, we're all equal. By the time we depart, the risk is the same. So I want to show you here 2 patients that I've just seen this week and last week in my clinic. Just read about this. Type 2 diabetes, ex-smoker, obesity, 4 years of diabetes, low HDL, which is a genetic thing, high HbA1c, normal lipoprotein A. And actually, if you look at his cholesterol profile, the triglycerides are not amazing, but his LDL is pretty much not bad, yeah? I mean, you see these LDLs every week in your clinic. And the HDL is, again, fixed, and there's not much you can do about it. But look at the amount of coronary artery disease that he has. Can I play this? Yeah. So horrible coronary artery disease with a proximal stenosis in the LAD. And what is more shocking about this is he's 31-year-old. Yeah? So it's a 31-year-old male with a multitude of risk factors and plus everything else you can't account for that having presenting like this. You don't see this in females of that age. You just don't see it, yeah? Unless you have a genetic predisposition like familial hypercholesterolemia, you do not see aggressive coronary artery disease in females in their 30s. You just don't. And this is another case that I've done when I was on call.
Sorry, why did he come to see you?
I can't remember, but I think it's because he had, I think he had some pancreas problem because of the triglycerides, and that led to one test and that's the other. Then we found it has symptoms, and then had a stent to the LAD there.
Did he have a low LPA?
Normal LPA.
Normal, so he has low cardiovascular risk.
Well,
Genetically.
LPA is one of the small incremental risks that you can have, but he is obese, he smokes, he has everything else. But my point here, he's 31, yeah? And as I said, if someone is coming if I'm on call tonight, hope I'm not. No, I'm not on call tonight. If I'm on call and there's a female coming, a 31-year-old, and they come to A&E with a chest pain and a possible heart attack, the first hypothesis that you think is spontaneous coronary artery dissection. You don't think coronary artery disease is going to cause an MI in someone in their 30s. It's very, very unusual for a female. And you see this all the time in males. So this is another case I've done. This is quite sad because this guy here is a bit older, 34. And he was at the gym. He was doing some gym stuff. He went home, had some chest pain. He collapsed, VF arrest, ambulance came in, did the whole thing. And then they brought him to us as a primary. He was quite late presenting. and we treated his stent, his LAD, but he was actually went to ITU. He didn't make it. He didn't die. He died in his mid-30s of coronary artery disease. Yeah. And what I want to show you this is what you use when you're placing stents nowadays. This is called intravascular ultrasound. And what you can see is a pullback of the LAD is full of atheroma. This is not something that developed in the last 6 weeks or 1 year. This is something that he obviously had a genetic predisposition to this. But this is a chronic condition that he has been building up inside him since he was a teenager, that now on his 30s. So if you just pause there, this is where the site of where the rupture was, the plaque rupture. Let's see if we can find it for you. There. If you see, this is his normal. It's here. And pause. So that is his normal artery, which is a black layer of muscle. And this is the coronary artery disease, is lipid, it's pure cholesterol, yeah? That ruptures, cause a heart attack, and obviously because he's young, he doesn't have collaterals, he has the FRS, and the rest is his. And they just heard the week after that he didn't make it. So the reason I'm showing you this is because obviously, I don't remember ever in my last 5-10 years doing this, seeing cases like this on women on their 30s or even their early 40s presenting with coronary artery disease like this, yeah? So for the first few decades, you are protected. God bless you. So what happened post-menopause in theory from our perspective, and I'm eager to hear later from Prof, is that the effect is dual here. You have a change in the traditional risk factors, the way the menopause accelerates your risk factors, and you have a direct protection of estrogen that you lose through the menopause. And that thing you're going to hear a lot in textbooks when we talk about vasodilation and endothelial dysfunction. The endothelium is actually in the layer of our arteries that actually controls a lot of blood flow. And if it's damaged, it will let the LDL particles enter the atheroma. And if you have an intact endothelial layer, that will not happen. So the theory here is that the estrogen will protect the endothelium against damage, and that's why you can smoke, you can have diabetes, you can have raised LDL, you can have a good time in life, and you still don't have coronary artery disease in the presence of estrogen. And when you compare the men versus the women life, sort of a time of LDL and triglycerides, it's pretty much that curve sums it up. You have a higher LDL as a man through your early life, then it goes up like everything else because of metabolism changes, but the woman goes up quicker through the menopause. To the ends, you probably have higher LDL on average than we have on average. And there's a theory that says that this sharp rise in LDL, in apoprotein B and lipoprotein A as well, is actually what caused a lot of the aggressive atherosclerosis you see after menopause. It's not just about the number, but the speed that it happens through menopause. And there's one big thing that happens as well, which you all have noticed if you go through the menopause, is the fact that you have a redistribution of your fat and your body weights, and you lose muscle. And instead of having this stereotypically female distribution of fat, you actually have visceral fat. And visceral fat equals inflammation, equals metabolic dysfunction. And this is the new thing about obesity and overweight. It's not about your BMI. It's not about how fat you are. It's where this fat is distributed and the proportion of fat you have with relation to muscle. And this essentially summarizes what's happening. You don't have, you lose muscle, so you lose your metabolic sort of factory. You obviously, for reasons that we're going to discuss perhaps later, there's so many behavior changes through menopause that you eat more, the wrong thing, you crave calorie-dense foods, and there is other direct implications there. But it's all about the redistribution of fat. And there is studies demonstrating this with MRI and ultrasound, that there is a very clear redistribution of fat in women through menopause. And without you gaining any weight, you increase your triglycerides, you lower your HDL, you increase your LDL, and everything else that leads to vascular disease. And this is just a summary of potentially how the mechanisms of the theoretical benefits of estrogens on your endothelial health. And it's all about the endothelial function. So everything that you see is bad for you, smoking, mental health, stress, lack of sleep. The single mechanistic link between the two and the cardiovascular disease is inflammation and endothelial dysfunction. And this is how we think that the estrogen is protecting you until you stop producing. So it sounds like it's an easy sort of theory here and an easy puzzle to solve. You have less heart disease when you're full of estrogen, and then you stop producing. You know, it's no point anymore. I'm not going to procreate. What's the point of having this? Then your risk goes up. So very obviously, at least for my dad, he used to be a doctor hundreds of years ago, it sounds like. And everything in that sort of mentality in the old-fashioned way was about mechanisms, yeah? So if you have low estrogen and your risk goes up, there's a very obvious treatment for to lower your risk after menopause, which is statins. Yeah? So it's not as simple, and that's perhaps why we're here for to learn, is that there is absolutely no evidence from any guideline or any study that HRT will protect you from cardiovascular events. Yeah, there's a different discussion here whether the appropriate HRT will perhaps be neutral or potentially improve some metabolic profile early, but the reality is none of the guidelines until major new trials come and change that view recommend using HRT for the purpose of reducing your risk. I'm not saying that you should not use it. I'm not saying that it's unsafe, but if anyone is referred to me to say, can you assess this person's risk to see if you can be given HRT to lower her risk? The first answer is that no, there's no evidence for that. Yeah. Now, a different thing is to discuss how we offer the HRT. There's evidence, we know that oral estrogen will increase your CRP. Again, inflammation goes up and increase clotting factors, and that's why increased risk of stroke. But it's interestingly, even though the early trials, I'm not, correct me if I'm wrong, but even in the early trials when we gave HRT to older people with established disease, there was no increased risk of myocardial infarction. Yeah, it was all about strokes and venous thromboembolism, but it's generally to be avoided in the high-risk population. And perhaps a good discussion for us to have, which again is not based on any evidence, is how do we define these high-risk people, these high-risk women who are a bit older and still having symptoms from HRT, to see if it's safe to give this to them. So this is the essentially the summary of the ESC. If you have an early HRT, someone on transition to the menopause, it's safe to do it, but it's in none of the situations, either it's established or late menopause, we're going to be using it to reduce cardiovascular risk. Okay. Now, going back to the point of screening, and going back to that longitudinal view of the disease across your lifetime, what is the point of screening? And this is perhaps when we're going to see a huge difference between what you do in the secondary, tertiary care and in the private sector versus what you can do and are allowed to do in the primary care in the NHS. So the NHS and the primary care, the way the funding works is that the decisions are made not only about your individual benefits, but it's all about whether that decision can be afforded by the whole population. Yeah. So things we will discuss here, which is the ideal way of screening atherosclerosis, is not applicable to the NHS because I simply cannot get everyone out there to have all the tests to detect atherosclerosis early. But that's sort of a different discussion, and we have to have a pragmatic approach here on how do we define risk, whether or not you have access to those tools, and pragmatically, whether you actually need those tools for patients who are happy to take the medication to lower their risk. So as a principle, what you have is that most guidelines will say that on the age, between the age 35 and 40, you should have your first overall cardiovascular screening, okay? That's assuming someone at low risk, someone who's never had a problem, no major family history, someone who's fit relatively well. Whereas we say that if you have any of those risk factors, if you have diabetes, if you have a strong family history of heart disease, you smoke, if you've been obese most of your early 20s, you should really have a look at things earlier, and you're in your 20s, 30s, or even on your 20s. And here, I pay a huge amount of attention to family history. The amount of people that I've seen in the last month with advanced coronary artery disease, either by having a first myocardial infarction or by presenting on their 50s, and they say, yes, my father had a bypass on his 50s, early 50s, and they haven't thought about having a checkup before they got to that point, yeah? So family history brings an element of the unknown that we don't really understand how this risk creeps up in some people. So family history is so important, yeah? If you have a family history, particularly if the family history is aggressive of many first-degree relatives or uncles and father and grandfather, and they all came early with multivessel disease or heart attack, you should have your first cholesterol by the time you reach 20. Because you want to know whether you don't have familial hypercholesterolemia, and you want to know what's the benchmark that you're going to be dealing with it in the future. And fundamentally, you can be offered risk reduction strategies that you can make a decision on what to do. Now, there's some other tests that we can do. We discussed lipoprotein A, which is the new kid on the block. Everyone is talking about lipoprotein A now. It's been around for 10 years, but it's finally coming in guidelines. That's why it increases your risk of events by 20-30%, maybe double in some circumstances, but it's still not the only cause. You can measure other fancy cholesterols, you can measure the lipoproteins around the cholesterol, and you can measure high-sensitivity CRP in some individuals. But these tests add very little or not as much in terms of decision-making compared to what you see on the right there. The principle here is that we're all born with that artery there, and what you don't want to have is the event on the right. This is the outcome for trials, and you're trying to prevent. You're not really trying to prevent atherosclerosis, yeah? Because, as I said, I'm happy to die with atherosclerosis in 97 with carotid plaques in both sides, but I don't want them to cause an event. So what you're trying to do is detect things early, not to reverse them, but to prevent them from becoming a clinical problem. And seeing atherosclerosis is the new way of doing it, more and more. And we do it in 3 ways: by calcium scores, by a full CT coronary angiogram, or by actually more increasing now using carotid ultrasound, which is relatively cheap and doesn't involve radiation. And that's when the discussions become a bit more semantic and difficult, because you can't really go back to your practice tomorrow and say, right, let's call all these diabetics on their 40s and let's get CTCA on them. It's just not going to happen in the NHS. But the mentality that you need to learn is that these guys have atherosclerosis in their arteries already, and we need to aggressively treat it. And this is a test that we use in the rapid access assessment clinic to help the nurse establish the probability of heart disease and detect angina and coronary artery disease by using CTCA. And what I want to show you here is that the CTCA has removed every other test on guidelines as early detection of angina. And the reason why is because it shows the disease directly. Everything else, treadmill tests, perfusion MRI, dobutamine stress echo, is an indirect way of looking at ischemia, where that test there shows the condition that is causing the problem. And you can detect early disease, you can detect calcium, you can tailor your treatment based on the amount of disease you have. And more importantly than everything else, if you have a normal CTCA, 0 calcium, no atheroma, the chance of you having a myocardial infarction in the next 10 years, if things don't change, is virtually 0. Providing that things don't change, and that's why menopause is important, because if you just say that and actually your LDL double in the next 2 or 3 years, then things are not quite the same. And once we define risk, which is essentially what we spend our life as cardiologists doing, we set up the targets for modification of that risk. And this is perhaps, if there's going to be a very friendly fight between the specialists and the GPs, it's going to be on this here. Because, and when I say the GPs, I don't mean individual like you, I mean the guidance that you're given. Because you guys are told that if someone has a bit of risk, you need to start someone on atorvastatin 20, and that's it. Yeah, that's the protocol. That's how things are going to happen. The reality is, it's much more. We see things in a much more aggressive way, and we need to reach those LDL targets according to the underlying risk, and we are obsessed with it, at least from our end, because we see the people coming in with heart attacks, etc. So once you establish a risk, and the ways of establishing risk, you can be very formal about it. You can go to QRisk3, that boring website, and spend like 10 minutes trying to find out that number. You can calculate your percentage risk, but you know the percentage risk can get wrong. I've just shown you some limitations of it. Or you can be very pragmatic and use other things such as your Lp(a), your family history, and explain to the patient. The way I do it nowadays, I explain to the patient, I say to them, if you have no disease whatsoever and you want to protect you from having anything at all, you should have an LDL of less than 3. But if you were to have a heart attack, you're going to bring your LDL to less than 1.4, which means this is the best strategy we can give. The best treatment for your preventing atheroma is bring your LDL to less than 1.4. Now, you decide how low you want it to be. Some people are very risk blasé. They say, you know what, I'm not really bothered. I might take a bit of a statin. I might go on a diet, and I'm quite happy with it. Some people will tell you, I will do anything you can offer me to lower my risk in the future. And every 1 millimole of LDL you reduce over 10 years is about 20 to 30% reduction in heart attack. So then you explain, if your risk is low, 20, 30% is not much. But if your risk is high, it becomes significant. And that's when you enter the discussion about lifetime risk. If it's 10% in 10 years, it's going to be much, much higher than in a lifetime. And that's why the approach now is that principle. The larger and earlier LDL reduction, the greater the protection. So if you have a heart attack today, you're going to leave the hospital with atorvastatin 80, yeah? But if you don't have a heart attack and you have a lot of atheroma there, then you're given 20 milligrams. So there is a discrepancy here between that approach that we need to close that gap by early identification of these high-risk people. And these are some slides that I've stolen from Raj Taka, when a GP with a specialist interest in cardiology gave a talk at Mayo for us. And he showed a few things that I also didn't know. The NICE guideline recommends some approaches, but you're not allowed to say that someone is not allowed to have statins because they have low risk. Because actually, if the people want to lower their risk, you can give them whatever they want. So it's not as if like you see I went to see a doctor and they said I wasn't allowed to be given a medication. No, for risk reduction, you're allowed to give anything that the patient wants. And there's a famous paper from one of my bosses in the past that he said, if you gave a sachet of ketchup, mustard, and statins every time someone has a burger, you're going to be lowering cardiovascular risk in the community. Because it's all about offering that little risk reduction in a low dose to everyone, to a large denominator of people. And there's other problems related to the difference between us. And one of the reasons why you see some data about this discrepancy is that we present slightly different. Yeah, the typical angina and heart attack in a man is a chest pain that can go to your neck and arm, textbook. Whereas with females have that plus a constellation of other symptoms that can present together with the chest pain. And that means that on top of this perceived low risk that you have, you see someone coming with some atypical symptoms and chest pains, you tend to dismiss it. And this is a big problem for us. Now, this is data from Raj Taka as well, a national data on the target and people who are on statins and on treatment. And what you see across the board for everything we look at is that you're always less treated than men. Yeah? You could argue that it's because the risk is lower, but every single thing we look at, whether you're on target, whether you're not, whether you take statins, whether you don't take, you are less than males. And this is a statins acceptance. And there's an element here also as well of self-reflected low-risk fallacy, where if you offer a statin to a female, she'll say, well, you know what, I'm a girl, I'm not going to have a problem, I don't need a statin. Whereas men would just perhaps more just take it. And you see this across studies and notice as well, that men are more likely to be on a statin, they are more likely to be offered a statin, they are less likely to decline a statin, and less likely to discontinue a statin comparing to females. And this is all part of the same sort of overall problem in terms of stereotypically describing females as low risk. Same thing applies to targets of LDL. No surprises that we are not, you're not as high as males are. So, to finish it off and to scare you a bit, I'm going to show you a case. Is a female, a 58 Caucasian female, who is a very low risk. Went through menopause, of course. Very posh tennis player, eat salmons and quinoas, highly educated, always have low BMI, no chronic disease other than a bit of migraine and reflux. Yeah? And then, did I miss one slide here? No. So then she comes to me in a social event after I had a few drinks already. And she said, oh, I had a chest pain. I was lying in bed the other night. Yeah. And I know she had reflux because she's my sister. Yeah. So she had reflux. And I said, oh, this is your reflux. Yeah. You're so fit. Don't worry about it. Yeah. But obviously, this is something I tell to everyone. You know, a lot of people text me about chest pains. And I said, look, I'm not here to be your cardiologist, but if you ever feel anything when you're exercising, when you're doing any physical effort, then you go and see a cardiologist. Don't text me, just go and see a cardiologist. So she did that, she was playing tennis, and then once she felt that she was running and then she felt a bit funny in the chest. So she had an ECG, a normal echocardiogram, and I said to her, go and do a test. And she, in Brazil, that's a few years ago, she saw a cardiologist who organized a myocardial perfusion scan, which you won't see very much in the UK. A lot of this is used in America. And she went on a treadmill. So this is an exercise perfusion scan. She did 12, 13 minutes on the treadmill. Amazing. She broke the records. She had no symptoms whatsoever. So a treadmill test screening would be negative and she'd be reassured and said, don't worry, you're just mad, yeah? And she had a bit of what they called apex abnormality or perfusion. At the very apex of the heart has a 5% of ischemia, which we consider a very low burden, yeah? Anyone who says to this person, don't worry, this is just a false positive, we had no symptoms, is a very sensible answer. But she called me and then someone wanted to do an angiogram on her, invasive angiogram. And I said, no, don't do that, that's crazy. And I'm an intervention cardiologist, yeah? So it said, let's do another test. And which test is the test that's going to give you the answer? Because all of these tests are going to be like, The CT was actually going to tell you, does she have atherosclerosis? And you're absolutely right. I managed to arrange a CT for her. And very important, this is the second thing you cannot forget from tonight. The first thing you do when you do a CTCA, you do the calcium score, which is a very quick screening of your arteries without radiation, 20 seconds. And then she had no calcium. Yeah? I mean, come on, what good news, yeah? So that means she's going to live forever. So calcium score is good on a populational level to stratify risk. It's useless on an individual level with symptoms to detect if you have atheroma or not, yeah? So when they said 0 calcium, my friend was actually doing this scan back. He needed to check and said, I knew that myocardial perfusion scan was wrong. And then immediately after the calcium score, she had a full CT cornea angiogram, yeah? And that is the result. She had a very, very severe proximal LAD stenosis with no calcium at all. Yeah, we can see that there.
Why did she have a normal ECG?
Because that's corneal artery disease. She had normal treadmill. She went for 12 minutes on the treadmill with no symptoms and no ECG changes. And of course, then we say she needs an angiogram immediately, and then she went to have it. And what I want to tell you about this is that nowadays, when you do an angiogram, it's not like quite the old-time cowboy thing when you just do an angiogram, bang, it stands and out, at least not my generation. There's a lot of technologies that I'm involved with developing that measure ischemia and imaging side. And what she had was this in her corneal artery. This is a subtotally occluded LAD. That artery, if another red blood cells decide to stop there for a bit, it will occlude if you have a massive myocardial infarction. Yeah, and of course the treatment for this is a stent. Yeah, and she did it. She did well. She's fine. But this to show you that it's a very funny disease, atherosclerosis. And now I know why some people get sweaty looking at ECGs. Because these things can happen, and you don't know whether that person is there. And I don't want to use that sort of exceptional case to think that the rule that everyone else with zero calcium will have a heart attack is not what I want to say. But what I want to say is respect the principle that if we don't look at atherosclerosis, we don't know that it's there. And we should not be using calcium score in young people. I mean, she was 58, so it was quite acceptable. But the amount of time I'm seeing people in their 40s and even 50s who say, I have a calcium score of 0, it's very reassuring. No, it's not. Because actually, there's the opposite. You go to the doctor, they tell you normal test, normal 0 calcium. Ha! What are you going to do next weekend? You're going to have a party, you know? Your LDL can double, you're going to smoke, etc.
What about lipid profile?
Yeah, so the lipid profile was very borderline. Lipoprotein A was negative, normal. She was very borderline. So she had chronic migraines. And what I think she had was that she was taking tryptophans, yeah? Tryptophans are known to cause vasospasm. So if you're taking tryptophan, you don't have any coronary artery disease, the amount of vasospasm you get is quite minimal, yeah? But if you have a newly occluded artery, that vasospasm is enough to cause you angina. And that's why she had that night. She had a migraine, she took some tryptophan, went to bed, and she had angina because of it, yeah? So actually the migraine saved her potentially, yeah, by taking tryptophan, paradoxically. So there is a gender difference between risk, but it's mostly a catch-up game of about a decade, yeah?
That's good. With giving a torvastatin at 80 and all those high levels, is there any danger of having too low?
Excellent question. And the short answer is no. So the best way of putting this to you is that the way, if you've heard of inclisiran, yeah, which is that medication, that drug was developed based on findings of families who were born without the PCSK9. So it's a mutation that they have loss of function of that receptor. And these people have LDLs of 1 their whole life. They live until they're 300. With no dementia, with no lack of cholesterol, glands. People claim that if you lose your cholesterol, you're not going to produce hormones. It's all nonsensical. And to the best of our knowledge, the lower your LDL, the better. So it's a catch-up game of about a decade, and you're a decade ahead of us or behind us, depending on how you put this. Women are underrepresented in studies and audits and undertreated for risk factors precisely because of this lower perceived risk. And after menopause, I'm afraid that protection is gone, largely. And having said all of that, the screening approaches and the treatment is exactly the same. Yeah, apart from having slightly lower risk early in life, nothing changes. So what we say is don't avoid screening because of gender and don't change your treatment because of gender. But in a young-ish women with very low risk factors, it's very good to be reassuring to say that on top of everything else, you have the protection of of being a woman. And be aggressive on risk reduction. And this is perhaps the only thing I want you to actually change your practice. Don't be happy with the standard 20 milligrams of atorvastatin if the patient is not on target. Chase that target, add ezetimibe, discuss with the cardiologist, consider inclisiran, change the diet, but make sure that the LDL is on target for risk prevention because it's a long game, yeah? And finally, very soon there will be, most of these images you've seen today, they are part of a book that is coming out that I'm writing about atherosclerosis for patients, yeah? But what is amazing about it is that by writing that book in a patient-friendly language, I've learned a lot. And I actually realized why we're writing books in technical terms is just a waste of time. And certainly for you guys that are non-specialists, it's a really good way of catching up with knowledge that you can actually explain to the patient directly. So it's not quite ready yet, but you've seen some of the figures already on this talk. And of course, any questions? I think you're going to go straight to the other talk.
Yeah,
Is any burning questions I can answer? Otherwise, we talk about it at the end.
Yeah, let me just start set up. Thank you so much, Ricardo. We're going to do more Q&A at the end. Thank you so much for your presentation. Very enlightening. I do agree with the statin. I think that we usually have the Q risk. I don't know if you guys remember. The Q risk used to be 20%. Yeah, now came back to 10%. And I do agree that we should be using more statin as well. However, I'm so pleased that you are here sitting tonight to hear some of the evidence on. So is this? Let's do one question to Ricardo while we set this up here. Yeah. So one question. So.
Yeah, at the end there.
So, but wow, oh, Nadia. Oh, I think that was not on. Oh, perfect.
Yeah, it's a big confusion. I've seen. It's funny to say this because the other day I've seen a very young person on the 30s who's seen a functional doctor who organized a calcium score, and the calcium score is about 30, which is low, but it's very high for his age.
Yeah.
So the point of that percentile that you see is that you index by your age, gender, and ethnicity. So as I said, if I'm 85 and I have a calcium score, I want to have some calcium there as a sign I'm alive. I lived a good life. But if you index by my age and gender, it's going to be normal. So if you have any calcium at your age 20, 30, you come at very high percentile. It is not a risk. It's the percentile that you are in the population of the calcium. So if you are the 25th percentile, there's 75 people there with more calcium than you and 25 less. That is all what it is.
But it sounds like it's a risk. So should we be doing something?
Yeah, well, so the way I put it is better than you not have calcium. That's better, yeah, full stop. But you do have calcium, but you're average, which means that you're not more than average in the population out there. Do you want to do anything to reduce that risk? Then you're open to the patient. You're not particularly high risk, and you're seeing atherosclerosis, yeah. Every time you say this to them, they will agree to do something.
So let's go for the second talk, because otherwise, because perhaps Professor Vikram needs to catch a train. He doesn't live in London. So our second speaker is Professor Vikram Talaulikar. He's a specialist in reproductive medicine and a professor of women's health at the University College of London. He is a menopause trainer for both BMS, British Menopause Society, and the FSRH, the Faculty of Sexual and Reproductive Health. He's a co-founder of the Menopause Research and Education Fund charity. I would like to present Professor Vikram in a different way because he is a very good friend of mine. So when I decided to become a menopause specialist, I said I would like to sit with that guy. He knows every single possible research worldwide on women's health. However, after being with him for more than 2 years, the reason that I cannot leave him is how kind, how nice a human being he is. So thank you so much for you being here and for you to be raising awareness of women's health and menopause. Thank you, Professor Vikram.
Thank you. So Ricardo, you've scared me enough now. I'm going to make an appointment soon. So we're going to talk about menopause. So I'm going to mainly focus on hormones, HRT, because actually you've done a lot of my job easier because you've set the scene. We all know that women, as they go through perimenopause, menopause will catch up with the cardiovascular risk. I'm going to more focus on some of the recent sort of developments. There's a lot of talk about HRT, both in terms of quality of life. Can we use it for prevention of heart disease? Where are the guidelines now? And what type of HRT, if at all, we are going to ask patients to take. So, a little bit about the background, and we'll rush through this because most of you see menopause patients and you know this already. So, premenopause is before any hormone changes happen. These are usually women below the age of 45 having regular menstrual cycles. They don't have a lot of symptoms. Estrogen, FSH, LH will be within a normal range. The first stage where things start changing is perimenopause, which is a lot being talked about now in the media. Perimenopause is when hormones fluctuate. So the ovaries are making less and less and less of estrogen. You're not ovulating more often, and so therefore less progesterone. Testosterone is gradually coming down, although it started coming down very much early, almost in the initial 30s, the testosterone is falling. but it continues to fall in the background. The main change here being the estrogen fluctuating up and down. And we've tried to test estrogen weekly or monthly, and there is a change. So sometimes patients ask, how much is the fluctuation? It's quite a lot. Even if you do weekly tests for estradiol levels, you will see low and high, low and high. So the ovaries are trying to keep up with the production of estradiol, but it's fluctuating. So that's the first phase where the periods will change. Initially, menstrual cycles will become shorter for most patients. Then they will become longer. So you'll have 2 monthly, 3 monthly periods. And then finally, menopause. It's a technical word. Menopause simply means there's no period for 12 months or 1 year. That's retrospectively technical definition. For most women, that will be 45 to 55. So it's a broad range where menopause happens. And then postmenopause. This is 1 year since the last period until end of life. And that's why we're talking about it, because from the time of the last period till end of life can be 10, 20, 30, 40 years or even longer for some. So you're looking at almost half the life or 1/3 of a woman's life, which is going to be postmenopause. And if you're not addressing good quality of life, bone health, heart health, brain health, then we've let women down, which is what has happened for generations. That's why the focus on postmenopause. The key here is, remember, symptoms present even in perimenopause. So just as I said, the estradiol levels are going to go up and down. Even if it's perimenopause and the woman is still having relatively regular cycles, very little change in her cycles, she could be still feeling a lot of menopause symptoms. Because on 1 week she's producing a lot of estrogen, the next week she's not. And although we won't have time to dwell on it, remember, hot flushes or vasomotor symptoms are actually a screen for cardiovascular disease. There's very little limited data, but if hopefully future research can characterize what sort of severity of hot flushes or vasomotor symptoms actually mean risk for cardiovascular disease, and those research studies are happening, fortunately, then it might be one of the things to say you're having more vasomotor symptoms, you should be even more aggressively looking at your cardiovascular health. But there is preliminary data that there is a link between the two. So timing of menopause, we know most of them 45 to 55, but there is a lot of variation based on where you live and what your ethnicity is. Median age for North American, European populations is 50-51. 10%, 1 in 10 will have an early menopause between 40 to 45. 1 to 3.5%, and that looks like a big range, because if you look at Western population, it's around 1% of premature menopause below 40. If you look at, say, African or South Asian populations, it's about 3.5%. That's a lot of women, 3 to 4 women out of 100 having premature menopause below the age of 40. About 1 in 1,000 below the age of 30. So never too early for menopause. We see girls, young women in their 20s who present with lack of periods, often being misdiagnosed as PCOS or hyperolactin or hypothalamic suppression, only to realize that the FSH is high and it's tested way down the line rather than somebody at 45. So that diagnosis shouldn't be missed, because for POI or early menopause, the earlier you go in with HRT, a lot of changes you will save from happening for bones or heart. Ethnicity variations, of course, we know if you're from Southeast Asia, you have 5 years earlier menopause. And again, I'm going to ask you a question at the end, Ricardo, whether you see this more in Southeast Asian women, for example, because they have propensity to have menopause much more earlier, so 5 years on an average earlier. That means they will have a higher cardiovascular risk probably, because they are having these changes to their arteries much more earlier. Okay, magnitude of the problem. I'm not going to dwell on this. Lots of statistics we've already seen, but that's the rough number that's been estimated that women die from coronary heart disease every year in the UK, and we know it's a leading problem. But something that Ricardo alluded to, research and data female specific are lacking. There's lots and lots of data about statins, about heart disease in men, but not enough in women. We really need to continue to kind of make progress in terms of making female-specific research that we can apply like for like, rather than extrapolating a lot of male research for female participants. Not going to go into that. Again, a lot of it was well covered in the previous topic. So you've got many risk factors in terms of lifestyle or lifespan approach for cardiovascular disease in women. The ones hormonally, which are most important there, being premature menopause, gestational diabetes, hypertensive disorders of pregnancy, preterm delivery, polycystic ovary syndrome, and any autoimmune conditions. Because remember, most autoimmune endocrine conditions or other conditions are commoner in women. And so all of them will have some bearing on the heart disease and cardiovascular health. And we often don't focus on this. We focus on the problem at hand. But actually, as Ricardo said, it's been building up for years and years and years until you get to the point when a cardiovascular event happens. And as GPs, you're best placed to actually look at some of those in terms of history during pregnancy, what happened postpartum, any other autoimmune conditions, and to put that together when you look at the risk for your patient. What happens with menopause? So now let's dive into menopause. What is it bringing on? It's bringing on risk. Why? Because before menopause, as we heard, lower risk of being affected by coronary heart disease. At menopause, risk increases. And we saw some of the mechanisms. So estrogen is heart friendly, keeps LDL cholesterol low, reduces risk of the plaques and the atherosclerosis. Again, if you look at hormone production from ovaries, perimenopause, menopause, we know it's going down. So although it's fluctuating, overall it's going down, and that's going to stimulate the atherosclerosis, the buildup of plaques. Finally, the blood vessels tend to be stiffer, so that again contributes to higher blood pressure, and it's a vicious cycle. That's going to again worsen the cardiovascular risk. Specifically about premature menopause, early menopause below 45, 40, there are plenty of observational studies. There is significant association with premature coronary heart disease. So this is the real target group in terms of early aggressive HRT, because risks are minimal, but plenty of benefits. And therefore, hormone replacement is really crucial for those with POI early menopause. And there are myths still prevailing. So you still see women way below 40 in their 30s from certain socio-ethnic groups or otherwise who are worried, I'm going to get breast cancer, I'm going to get a stroke, I'm going to get blood clotting. That's not applicable with the kind of HRT we have now. If you have gone through early menopause or premature menopause and you start HRT as a replacement, you do not have any increased risk of breast cancer until you get to 50. That's completely proven through lots and lots of observational studies. So for this group specifically, HRT does not bring in any risk of cancer. They should be advised to start as soon as possible. Generally, how does estrogen protect cardiovascular health? And again, are those the mechanisms that some of the nice pictures we saw, the direct effects and indirect effects. The direct effects, of course, are vascular function, endothelial function. There's some nitric oxide dependent vasodilatation. There is inhibition of calcium dependent channels. There's vascular remodeling of the collagen, the enzymes which work there. All that is favorable when estrogen acts on the vessel. But equally important are the indirect effects. So we talked about the redistribution of the fat, the insulin resistance, the central obesity. All that is going to increase the inflammation and contribute to atherosclerosis once that action of estrogen disappears. Addition of progestogen. This is interesting. What happens when you add progestogen to the estrogen? And we're going to come to HRT later. But because we are at the hormones now and their action, estrogen is all good for heart and blood vessel. But what about progestogen? There is known effect of oral synthetic progestogen, the ones which were used traditionally in old HRT. They seem to reduce the benefits of estrogen in HRT. They're not directly causing something to the blood vessels or heart, but when combined with estrogen, they are going to reduce the efficacy of estrogen in the HRT. If you're aiming to give HRT for some benefit to the cardiovascular system. And which are the better progestogens? We'll come to that in a minute. So estrogen seems to be the key hormone here for cardiovascular benefit. Either alone, for women with hysterectomy, we give estrogen alone. For those with uterus still there, we need to combine it with progesterone. So we're going to have to find out a way how best we can give it in menopause if we give it. So what do we know so far? So estrogen replacement reduces incidence of cardiovascular disease if offered early during menopause. And I'll come to from where we get that information in a minute. Women who have a uterus will need estrogen with progesterone. We know that they need a combined HRT. If you look at long-term follow-up data, looking at HRT and health outcomes, it does not obviously show a detrimental effect by combining estrogen with progesterone. So although we know oral progestrogens can have a little bit of resistance to good action of estrogen, the good thing for us is long-term follow-up data from large studies, observational studies, does not show that there is so much of a resistance to the good action of estrogen from progestogen or progesterone combining. Let's look at where the evidence comes that there may be some benefit with HRT for cardiovascular health, and can we rely on it for prevention? So first of all, the big study, the gold study, which happened 20 years ago, was the WHI, the Women's Health Initiative. It's been criticized for many reasons. And of course, it had lots of flaws. For example, older patients, more than 60, more than 65, the kind of hormones used were equine estrogen, medroxyprogesterone, which we don't usually use as first line now. But anyway, they pulled all the patients together between 50 to 80 and said, HRT increases risk of heart disease, more risk of heart disease. And that's where they got the criticism, is because they had actually taken patients with existing comorbidities and then subjected them to quite significant hormones, which of course meant they got worse disease events. So then it was stratified. They looked at different groups of women, 50 to 55, 55 to 60, 60 and above. They stratified. They also followed these patients up for up to 20 years, and the follow-up still continues, which is great. What did the long-term follow-up data show? So that showed there is no evidence for such a detrimental effect, even with either estrogen alone or combined HRT. So the conclusions turned around. In 20 years, we now know that even with the WHI study, which was a gold standard RCT, combined HRT followed up to 20 years with patients with no existing comorbidities and below age of 60 did not show a detrimental effect. And women below 60 years of age who were using estrogen only, so this is the hysterectomy arm of the randomized trial, there was a significant decrease in coronary events. So there was positive association. So, yeah.
Can I ask a question? Because folks seem to be studying different things about.
We'll come to that at the end.
Okay, and can I just ask about unopposed estrogen?
Yes.
Whether that's the same thing?
Sorry, that's for hysterectomized patients.
Sorry.
Hysterectomized
Okay,
patients.
fine.
So the WHI study had a hysterectomy arm,
Yeah.
estrogen only, and you had a non-hysterectomy arm where you combined equine estrogen with medroxyprogesterone. So two things we saw: long-term follow-up, estrogen only, some benefit; combined HRT, no detriment, as we thought initially when we combined all the patients together. Now Cochrane then said, let's do a meta-analysis, let's do a systematic review of all the studies that are pulled together and see what happens. So they did a review which is relatively old now, needs an update in 10 years time. This was 2015. And they said, let's see whether we can use HRT for prevention of cardiovascular disease in postmenopausal women. So this is trying to see whether you can use HRT for primary prevention. Like you would say, good diet, exercise, statins, and you use HRT as a preventive measure. So they looked at all the placebo-controlled RCTs, randomized trials, total number of about 9,000 plus women, and they found that there was a reduction in all-cause mortality, 6 fewer deaths per 1,000 women in those who had started HRT within 10 years of menopause. So they drew a line somewhere about 10 years of the last menstrual period. And they said women within 10 years of menopause, and let's look at women after 10 years of menopause. And they did find there were 6 fewer deaths, all-cause mortality, in those 1,000 women per 1,000 women who had started HRT within 10 years. What about other outcomes? So again, they looked at placebo-controlled RCTs, about 8,300 plus women who had 8 fewer deaths per 1,000 women from coronary heart disease in those taking HRT compared to placebo. So this is again in women below 60 or less than 10 years since the last period, some benefit, 8 per 1,000 less deaths from coronary heart disease. Then they looked at women beyond 10 years taking HRT after 10 years of menopause. A neutral effect was what was noted in women who had started HRT more than 10 years after menopause. No difference in mortality, no difference in coronary heart disease compared to placebo or no treatment. So the Cochrane suggested that if you offer HRT to somebody within 10 years of having gone through menopause, there was some benefit to the heart disease risk, so less events and less coronary deaths. If you offered it after 10 years, it didn't seem that it was giving any benefit, but the effect was neutral. It did not mean that you would necessarily have lots of coronary heart disease events. So this is purely in relation to HRT starting either within 10 years of menopause or after 10 years. What does NICE say on this? The NICE published its guidelines last year. It updated the guidelines which came out in 2015. And so it said, again, the same thing, coronary heart disease risk does not increase on HRT, even with combined HRT, knowing that some of the older forms of HRT could have a progestogen that could lessen the benefits of estrogen. But fortunately, again, looking at different combinations in women somewhere between 50 to 54, the mortality from cardiovascular disease or coronary heart disease did not increase with combined HRT. That's a very important conclusion because over the years and years there has been fear built up that HRT would cause increased MI or heart disease. And that's one of the reasons why women don't take HRT sometimes. And that's not strictly true if you look at the data. HRT may not be for primary prevention, may not help necessarily everybody, but it certainly doesn't mean you're going to have more coronary heart disease if you take HRT. That's a really key message here. So when best to start HRT, who should take it, who should we be giving it to? We know HRT started before age of 60, within 10 years of menopause, is associated with some reduction in atherosclerosis progression or coronary heart disease. There's no increase in events, cardiovascular mortality if you start it after 10 years. You may not have the benefit, but certainly no increased mortality or events. So if you're giving HRT for treating menopause symptoms, starting early becomes important because the earlier you offer it, lesser the chance of atherosclerosis progressing, and whatever little benefit that will come from your HRT is going to be important for the patients because even that little bit of advantage for their cardiovascular health is what they will gain from it. And it also means that you can't not start HRT after 60. So if a patient comes to you and they're above 60, often the worry is, oh, you're above 60, I can't give you HRT. No, that's not a rule. You have to individualize. If the patient still has quality of life benefit, still is having symptoms and wasn't given HRT in the past, you can sit down, explore the risk factors, and still reach a decision where you can offer HRT even after the age of 60. Not everyone needs to or wishes to take HRT. So this is not to say every menopausal woman should take HRT. No, it's a treatment for symptoms and quality of life. So therefore, not everyone will take it. But for women who need it, it shouldn't be denied because of wrong information. HRT currently is not recommended by any guidelines for primary prevention. So remember, it's a treatment for menopause symptoms. Yes, it has benefits for heart, that small 18,000 benefit. For women who will take HRT, it's a side benefit. Just like we say for bones, it's a side benefit of prevention of osteoporosis. But HRT is not a primary prevention tool right now. It's not given only for preventing heart disease. If the woman doesn't have symptoms and doesn't need HRT, other than if she has premature or early menopause, she does not need to be on HRT. That's not an indication. What HRT is preferred? So let's say now we have a woman, we're going to treat her for symptoms, whether she has risk or no risk. The standard guidance right now we use is estradiol, 17-beta estradiol, and the first line progestogens we use is natural progesterone or dydrogesterone. These are the two best progestogens. So these should always be the first line treatment for anybody, whether at risk of heart disease or not. For women above 60, BMI above 30, risk of thrombosis, comorbidities is the transdermal estrogen which we will recommend. Of course, because we know oral estrogen can increase clotting factors in the liver and we don't want risk of thrombosis. So anybody above 60, high BMI, comorbidities, always transdermal estrogen. That also means that you can safely offer oral HRT below the age of 60 if there are no comorbidities or if there are no underlying thrombosis risk factor. Because sometimes you may find transdermal HRT with the progesterone very difficult with bleeding problems or other issues, and giving an oral combination may actually be better for bleed profile. There was another paper from the BMS, HRT after having myocardial infarction, very useful paper, very quick read, about a couple of pages. And it again stressed the same, that don't deny HRT just because somebody has had a heart event. Remember that if you stick to estrogen in a transdermal way, if you combine it with a progesterone which is more friendly, such as a non-androgenic progesterone, natural progesterone or dydrogesterone, you can still offer HRT or continue it despite having an MI or a cardiac event. So you can continue HRT in that situation, consider whether the patient will have statins or not. That will usually be dictated by the cardiology team. And again, they need a bit of a specialist input there. So either a specialist menopause clinic or a specialist cardiology clinic, and they often teams should be talking to each other. But individualizing, that's where it comes. Whether the patient is risk averse or whether they are wanting to take certain amount of risk to preserve their quality of life, everybody will be different. So respecting that and making a shared decision there will be the key. I'm not going to go too far because do we have time?
Yeah, you can
Yeah.
go a bit more.
I
Yeah.
have probably another 5 minutes.
Okay.
Perfect.
Yeah, that's
So-
fine. Yeah.
Another consideration is risk of stroke. And again, there's a lot of data here, but I'll skip the slides to keep it short. Large observational studies show that transdermal estradiol, the patches gel spray we use, is unlikely to increase the risk of stroke above non-users. So lower risk of stroke compared to oral estrogen. We know this very well. Initially, there were some studies which suggested if you stick to a low dose, for example, look at the second one, a patch dose of less than 50 micrograms a day, there's no risk. But if you use a higher dose patch, for example, more than 50 microgram or 3 or 4 pumps of gel, the higher you get to the highest licensed dose, there may be some risk. But the study was criticized for many reasons. It had very wide confidence intervals. So people then decided to do even larger studies. And actually what we found is within the licensed doses regime, whether it's the smallest dose or the highest licensed dose, you don't seem to have an effect depending on the dose. So if you stick to the licensed dose of a patch gel spray, none of the transdermal HRTs seem to increase the risk of stroke. So what we can safely say now is, generally if you're sticking to transdermal estrogen with one of the newer progestrogens, the dydrogesterone or the progesterone, the risk of stroke does not increase as long as you're within the licensed dose regime. What about HRT after stroke? Somebody has had a stroke and now she's coming to you to say, I want to have HRT or I want to continue HRT. Now this is slightly difficult because there is no good quality data post-stroke. And that's because traditionally anybody with stroke has been denied HRT. You were asked to go off HRT completely. So we have to rely on small studies or case reports or individual experience for that. At the moment, it does appear that if you have somebody after stroke and there is no ongoing risk factor for stroke, for example, the stroke was because of a flight or because they were taking a pill or because they had some other condition, infection, sepsis or something else that was causing a stroke, or an arrhythmia that caused it, and now it's been treated and then anticoagulated. If that's been controlled, then you can offer still transdermal estrogen and a favorable progesterone. So you can offer HRT, but it's important to tell the patient we don't have a lot of data and we are treating when the benefits will outweigh the risk. So just like with MI, low dose transdermal estrogen, a favorable progesterone or dydrogesterone, but caution the patient that we have to go by individual situation rather than a lot of data backing us. POI, we talked about premature menopause. How long do we continue HRT? At least until 50 or 51. And that's because we want to make sure they have enough estrogen at least until the age of natural menopause for their bone or their heart outcomes. So the difference between POI and somebody having menopause at 45 is, when you give HRT for POI, you want to give it till 50, preserve their bone, their heart, their metabolic, and their cognitive health, even if they don't have symptoms. That's primary prevention. HRT can be used there to prevent heart disease. They don't have to have symptom issues there. But somebody going through a natural menopause after 45 have had their lifetime of estrogen, HRT is not recommended for primary prevention. It would mainly be only for symptoms and quality of life. And the similar thing is with the risk. So if they're taking it for POI or early menopause, they do not have an increased risk of breast cancer till they get to 50. But anybody taking HRT after 45, there is always HRT association with a small increased risk of breast cancer, which you have to balance against the benefits that you are expecting.
Did you say 45 for that?
That's right. So lifestyle management still remains the key. If somebody is having a poor lifestyle, HRT won't cause change, remember. Again, underpinning cardiovascular health will be all that what Ricardo spoke about, the cholesterol, the diabetes, the blood pressure, the smoking alcohol. HRT only gives a little bit of additional benefit, but it's not going to work if the lifestyle is not optimal or all the other conditions are not managed. So to conclude, we know HRT for menopause has benefits, quality of life, bone and heart. If started early within 10 years, benefits outweigh risks such as breast cancer for majority. Women with established heart disease, those who have vasomotor symptoms, despite non-hormonal options if they want to consider, then you make a decision regarding use of HRT based on their individual situation, and you can offer it after an MI or a stroke. Guidelines now do recommend low-dose estrogen, especially after an MI or a stroke-like event. We don't have a lot of data. We'll hopefully get more in future. Oral HRT is something that we avoid in any high-risk situation because we know, one, it can impact blood pressure, and it can, of course, increase the risk of thrombosis. So I'll stop with that, and hopefully we'll have lots of questions.
Thank you, Vikram. Very enlightened. Well, we could have some hands. You first, yeah?
So since I turned 58 today, 60's coming very fast.
Happy birthday.
How